thank you for joining us here at New Teeth Now, where shortly we will be joined by none other than Dr. Harley Richards himself, and we will be talking about the New Teeth Now procedure. How are you doing today, Dr. Richards?
Doing well, thank you.
Good. So let's take a look at your first slide. So this is you, and there's some key points on here that I wanted to talk about. So you are a board certified oral surgeon.
Right.
What does that mean? Why is being board certified so important?
Well, board certified would indicate that a person meets a certain standard established by a board of that person's colleagues in his or her field. So it's would indicate to the public that your doctor, regardless of the field that he or she is in, meets a certain standard that has been set by their colleagues, and supposedly board certification would mean that you're assured, that the public is assured that the doctor they're dealing with is of the highest standard.
Wow, so you are constantly doing schooling and you are constantly learning about this.
Sure we do.
All the
Absolutely.
time.
Yeah. Yeah, I mean, everyone goes to educational seminars and things of that nature, so absolutely.
Not to mention that you're doing these procedures back to back daily.
Correct, yes. Yeah, these procedures for sure, yeah.
And it also says that you have 35 years of dental experience, is that correct?
No, that's not correct. It's actually 37.
30? You don't even look 37. How is this possible?
No, I started in Lakeland in 1980. So that was, according to my calculations, about 37 years ago.
Wow.
Which means I'm getting to be an old guy.
But it also means that you actually started up this whole New Teeth Now procedure. So it says you're an innovator. What do you mean by an innovator of New Teeth Now?
Well, I mean, we meaning Dr. Musser and I, because at that point in time, Dr. Kirkpatrick, he may not have been born at that time, but we started placing dental implants. I think Dr. Musser did it in the 70s. I did in the late 70s as well. And it's just been a continuous evolution in what we do, and also a continuous evolution in the technology of the products that we use. And you would find this in any field, whether it's lenses that go in our eyes, whether it's artificial hips or knees, whether it's dental implants. You're going to find that if you look back 37 or 40 years, what we're doing in 2017 is not what we were doing in 1980. And nor is the technology the same. The products that we use are better, and all sorts of things have been discovered over the years to make things better.
So we've come quite a long way from just the traditional all-on-4 procedure.
Oh, absolutely. Yeah, what we're doing now is much better. Yeah.
Very interesting. If we go to the next slide, let's talk about what is New Teeth Now. So this slide demonstrates a good picture. What's going on?
Well, that's just a picture of the teeth, a set of upper teeth. But what New Teeth Now is a process that we have innovated over a long period of time, and it allows us to consistently, repetitively give people new teeth the same day, consistently, accurately, where things look good, the bite is correct, and we're able to move them through this New Teeth Now process without any glitches, so to speak. So we have innovated, we have made changes over the years, I would say particularly the last 15 years, to allow us to have this New Teeth Now process that is, we've got it down basically to where there's no bait and switch. When you come in here to see us and we evaluate you and your medical history and your CAT scan, and we tell you that we can do this for you, then you can be assured we can do this for you because this process has been perfected.
So the difference between a denture and the fixed upper hybrid, what are the main differences?
Well, a denture is a large piece of plastic that fits, say, over the jaw and relies on suction to hold it in, and it would fully cover the palate and it would be large. The implant-supported bridge work, like the picture that you see, this is a bridge. We will have some other x-rays of bridges, but dental bridges have been done for hundreds of years.
Right.
Typically, dental bridges have been placed on teeth. And so most lay people, non-dentist people are familiar with bridges. And what the picture you are seeing is a bridge, but it is supported by implants, not teeth. And it has little screws that go through the teeth to attach the teeth to the implants. And so this is the type of thing that we're talking about doing in one day. On the upper jaw, on the lower jaw, or on both jaws at the same time.
Now in the lower jaw, the implants are angled slightly. What's
Right.
the purpose of that?
Well, this is a technique that is used worldwide, and the implants are angled to avoid certain anatomical structures. In the lower jaw, there's a nerve that we need to avoid, and the angulation allows that. And in the upper jaw, there's the sinus in the rear of the upper jaw, and by placing angled implants in the upper jaw, we're able to avoid the sinus.
So you have to be a real perfectionist or have it down to an art in order to miss things like the sinus and the nerve that runs along the lower jaw.
Right. I mean, you need to know what you're doing. This is not the kind of thing that you go off, that a general dentist goes off and learns on a weekend course kind of thing.
That's what
I mean, this is what we're doing now is a culmination. What I did today, I did one of these today. I did one day before. I did one yesterday. I'm doing
And the
one.
day before that.
I'm doing
and the
one
before
tomorrow.
that.
Okay.
Yes.
So, what we're doing today is a culmination of years and years and thousands of implants, hundreds of people, each of us who do this. And so the people who we are doing this for now are enjoying the experience that we have gained over years and years and years and years, and thousands of implants to do what we're doing today.
You couldn't even count them, huh?
No.
No. So I think that's super important to make sure that you're going to somebody that does do this on a regular basis, because I certainly wouldn't want to just go to somebody, like you said, in a general dentist office that sedates me and says that they can do this when they haven't even placed.
Right, and then even a more experienced doctor might do 6 of these a year. And, we do anywhere from 20 to 30 people. We do this procedure on, say, somewhere between 20 and 30 people each month. And some of those are, I would say probably 75-80% of them are both jaws. So we might do, you can do the math there pretty easy. We might do 50 jaws, 60 jaws a month. So
That's a lot of experience.
Yeah.
I definitely would want to go there. So definitely come to us here at New Teeth Now. We have somebody actually that had this procedure done. I don't know if you remember her, but Charla. She's got a great before and after. Now look at her before. Why is she not smiling?
well, her dentition is collapsed and she's overclosed. And she didn't like her smile, so she didn't smile.
That's so
And
sad.
so it shows. And so anyway, that's very common when people are embarrassed of their teeth and they don't smile. And I would say that is one of the most frequent things that brings folks in to see us, is they are embarrassed of their teeth.
That's got to be quite rewarding to be able to give somebody a gift.
And then what you can see the result of
Right.
being happy and proud, and
She even
She
looks like
knows
she
she
lost
looks
some
good.
weight.
yeah.
She looks like she's lost some weight.
Well, it's not uncommon for people to eat better and to, once a person has a increased self-awareness and worth, and they feel better about themselves, and they are going to take better care of themselves.
She looks great.
So, when you have a mouthful of bad teeth, it's hard to feel good about yourself.
Well, let's go ahead and watch her video testimonial.
Before New Teeth Now, I was in a lot of pain. My teeth were all loose. I was losing them one at a time. That's what made me pick up the phone and call New Teeth Now. My first appointment, I was very nervous, but Dr. Richards and the staff and everyone there made me feel so welcome. The day of surgery, I can't say that I was nervous. I have to say that I was excited. I was going to wake up and not have those teeth anymore and not have the pain anymore. I was really ready to get it done. My recovery after New Teeth Now was so easy. Now I have the best time with my grandchildren. I take them to parks, I laugh, I smile, I talk to people. It's just a whole different lifestyle. And I would recommend anyone that's going through pain or having teeth problems to go visit Dr. Richards. It makes me feel wonderful to know that I finally have a pretty smile after all these years, and I get to show people who I really am because I have a beautiful smile.
Wow, she looks and just seems like a whole different
Seems
person.
a lot happier. Yeah.
Yes.
Absolutely.
I wish that we had a video of an interview of her before,
Yeah.
just to kind of
Yeah.
compare, because just how happy she was talking about that whole procedure.
Well, you know,
and about
when
you.
people feel better about themselves, I mean, they change their hair, their makeup, the way they dress.
Mm-hmm.
Generally take better care of themselves.
She did. She
Yeah.
looked beautiful.
Absolutely.
But I actually have included some slides about the zygomatic implants.
Okay.
Zygomatic implants are not very well heard of, never mind practiced. And you three guys have been doing zygomatics for how long now?
2007.
Since
So 10
07.
years. Yeah.
Wow.
Yeah.
And they've been really successful for you. First of all, what are zygomatic implants?
Well, we see a lot of people who have bone loss in the upper jaw. And all of us in this business have done the so-called sinus lift procedure over the years. And in my particular situation, back about 2004, I encountered a person who I ultimately became close friends with, who had a sinus lift and failed to form bone. And we took that out, put more bone in, that failed to form bone. And I was looking for a solution for her, and it just happened that at the Nobel Biocare International meeting in Las Vegas in May of 2007, they were talking about something called zygomatic implants. So I went out to that meeting to check that out. Ultimately, I was introduced to and put together with a lady surgeon in Toronto by the name of Leslie David. And she had learned how to do zygomatic implants from Chantal Malavez, who is the goddess of zygomatic implants from the Netherlands. And so I went up to Toronto. We placed 3 zygomatic implants. Spent the night. I came home and I placed 2 zygomatic implants the next day on my first patient.
Wow.
So we've been doing zygomatic implants since 2007. And there's zygomatic implants, and then there are zygomatic implants. And so that technology, at least in our group, has expanded over the last 10 years. I went to a zygomatic meeting up near Pittsburgh in 2008. There were 20 people there. I went to a zygomatic symposium in New York in 2009. There were about 100 people there.
So it's gaining popularity.
There was a zygomatic symposium in Vegas. Had about 2,000 people there back about 3 or 4 years ago. And so the zygomatic implant, which initially was thought to be some renegade thing, has now become accepted. And We just happened to get in very early on the curve. And there were a couple of other doctors around the country. Ed Petrosian out at the University of Washington in Seattle was in on this very early on the curve, like Dr. David, like me, like us. So, but zygomatic implants have enabled us to take a person who has no bone in the upper jaw and place zygomatic implants and give that person teeth the same day, where previously this was impossible to do. Sinus lift is a good procedure, but for the person who has no bone and who wants teeth, it's a 24 month process that is less predictable by far than the placement of zygomatic implants. So they are a workhorse in our practice, and we do them routinely. We've done probably well over 1,000 in the last 10 years.
Now, they're only successful when you're replacing all of the teeth, correct?
Zygomatic implants are used for a full, like the picture we showed earlier of the full upper bridge, and the picture you're seeing now on the screen, where there are 4 traditional implants in the front part of the upper jaw and 2 zygomatic implants in the posterior upper jaw.
Would you say somebody that's worn a denture for a really long time?
It's severe bone loss in the upper jaw, absolutely. Someone who has worn a denture for a long time may have no bone. But we see that situation with people who even have teeth, who have advanced periodontal disease, where the sinus is at this level, the bone used to be at this level, they've lost all of that bone due to periodontal disease, and now they have no bone.
Oh, wow.
So there are several indications for zygomatic implants, which would be too technical to really,
get into,
for folks to really, absorb and comprehend. But there are specific reasons. We don't just place zygomatic implants. There are certain specific indications when we place zygomatic implants. If we can do traditional implants or tilted implants like we talked about earlier, then we'll do those. But when the traditional and the typical techniques cannot work due to anatomical variations, then it just so happens, it's just really weird. I was thinking about this driving over here today. It's like zygomatic implants are perfect when people have this little tall, skinny bone. It's just, I don't know, it's like nature and everything just kind of worked this perfect for the zygomatic implant.
To clarify, while you were driving here to the webinar today, these were the things that were going through your head.
Well, I knew we were going to be talking extensively about zygomatic implants, and I was
implants?
just no.
Okay.
You don't want to know what I dream about, but it just is weird. And it's good how it works out that the specific things from the bone standpoint and the sinus standpoint, those specific things that do not allow us to place traditional implants are perfect for zygomatic implants. And it's just strange how that works out.
Taking a look at this picture, there's a lot going on, especially in the lower jaw here.
Right.
And since I'm not a dentist whatsoever, explain to me a little bit about that, because it's interesting. There's like normal teeth and then there's implanted teeth.
Well, we've used this slide, as you know, on numerous occasions to talk about bridge work. And I said earlier that most people know what a bridge is. You have teeth attached, caps attached to natural teeth. And so as you're looking at this slide, on the bottom right are 3 teeth. So down here, this is a dental bridge. These are caps on a cap or a crown on that tooth, which has a root canal, and a cap or a crown on this tooth, which has a root canal, and it's bridged. In other words, this is all one unit. These are glued on.
But it's not permanent, so that
It
is
is.
eventually...
That is permanent. That is cemented on, and you cannot take it out.
However, it's not going to last them forever the same way the implants are.
Well, the average bridge probably 15 years. If you're out 15 years and beyond, you're maybe on borrowed time. The same thing on the opposite side. And this is what I said earlier. It's just a bridge, but it's a bridge, 3 teeth, 1, 2, 3, except the supports are implants. So it's a bridge supported by implants. Now let's look up top. Now we have 6 implants. So this person gets a bridge on the top that is supported by 6 implants. So it goes from one side all the way around to the other side. So what we are talking about when we talk about the new teeth that people get, it is a bridge. So it is supported by implants, it's not removable, it's retained to the implants by screws, not glue, not cement, so it's easy to remove for maintenance and cleaning and that sort of thing. So this slide has a lot of information in it.
Yeah, no, I love this picture. And underneath the bridge, there's not going to be decay or the worry of the teeth rotting because there are no teeth.
Right, well, yes, and the main issue with a tooth-supported bridge is that under here in this margin on the front of the back tooth and the back of the front tooth, if you don't clean well under there, because you cannot floss in between these teeth. This is all connected. You cannot floss in between these teeth. It's all one unit. And you cannot floss on the top. This bridge up on the top is all one unit. But it just makes a excellent representation to show that all we are talking about is bridge work supported by implants.
Right.
It's nothing fancy. It's just that we do it in one day. And we use a lot of special techniques like zygomatic implants, which we have. And there's sort of the primary zygomatic implants like you see in this picture, but we have some other slides that I'll talk about in a few minutes, which are very advanced zygomatic techniques that we do here every day on a routine basis.
Oh, this one talks about mini implants. I did want to bring this one up because a lot of people do call in and they ask me what's the difference between mini implants and traditional implants.
For the purpose of the type of teeth that we are talking about, that we've just spent a lot of time, Emily and I have, explaining that when a person comes through the new teeth now process, they end up with a fixed bridge supported by implants. Many implants cannot do that. Many implants support removable dentures. Big difference. Many implants support removable dentures. They're many. They're small, and we take out a lot of mini implants. We don't do mini implants. We do not place mini implants. We remove mini implants. But let's move on. This is the slide I wanted to talk about. And the other slide showed situations where in the front part there was enough bone to place traditional implants with zygomatic implants in the back. I'm doing one of these tomorrow. And we see a lot of people who have no bone in the front and no bone in the back.
Wow.
These are the folks that have really advanced bone deterioration. Maybe have been wearing that denture for 20, 30, 40, 50, maybe 70 years they've worn a denture.
Right.
I mean, we've seen people in their 80s that we do this for. And so you can see in this picture there are 2 zygomatics on each side. And then if there's enough room to sneak a short traditional implant up into the septum of the nose, we'll do that just to add more stability. Or occasionally there might be enough to put, you see these implants that we have some really short ones now, like 5 and 6 millimeters long. That's like a 1/4 inch. They don't do well by themselves, but when you combine them with others and tie everything together, they do okay. And so, a couple of short traditional implants can take a little bit of load off of the 4 zygomatic implants. And on the right slide, you see the extreme situation where there are 4 zygomatic implants and no bone in the anterior for any traditional implants. And so these are the indications where we use zygomatic implants.
Why is it not needed in the lower jaw? Is there a difference in bone?
There is a difference in the bone. There's a difference in the anatomy, the nerve rather than a sinus. And so typically there's enough bone in the lower jaw to do these usual and customary typical techniques.
Right.
Okay. We do run into occasionally people that have a pencil-thin lower jaw, and we might have to do something different. Maybe we can't do new teeth now for those people. So occasionally, someone will come in who's been wearing a denture for years and years, and they literally have, a pencil-thin jaw.
Wow.
And there are some situations, if that jaw is pencil-thin and pencil-wide, that we cannot do new teeth now because there's not enough bone.
But there's an alternative, and you would go into that.
There
with
are
them
some
at the
other
consult.
alternatives, but we don't run into many of these people.
Got you.
Yeah.
I think that what we want you to take away from this is that if you've ever been told that you cannot have implants, that you don't have enough bone, that implants are out of the question for you,
Yeah.
you need to come in and sit with Dr. Richards one-on-one and get an honest evaluation, because you're definitely going to be honest.
Yeah,
with them,
I mean,
aren't you?
it's becoming more and more commonplace. I talked to a young couple yesterday from Clearwater, Florida, I was the third person that they talked to, and the other two doctors had talked to them about sinus lifts and that sort of thing. And I mean, I have to admit, I used to do it that way prior to 2006, 2007.
Mm-hmm.
But I don't do it that way anymore because there's a better alternative, and it's called zygomatic implants. Quicker, safer, more predictable, a simple office procedure.
Mm-hmm.
So no grafting. Zygomatic implants require no bone grafts.
And just to reiterate, it isn't when we're talking about single teeth. Single teeth are done extremely differently. This is for the new teeth now procedure when they're removing all of the teeth, correct?
Right. Yeah, very important to understand that zygomatic implants are for the full upper bridge, not for singles, as Emily said.
Yeah, I don't want people thinking that they can come in here and you're a magician.
Right.
That doesn't, if it's a single tooth, then maybe a sinus lift still involved.
Yeah, we do, exactly. We do sinus lifts for other procedures, but not for the full upper, where there's advanced bone loss.
Right.
Right.
Why? When you've got the technique
Yeah.
and the experience that you guys have.
Right.
So let's take a look at your gorgeous team here. Now, these three ladies, do they all assist you during the surgery?
They do, absolutely, yeah. Actually, those three Denise has been with me well over 20 years, and the other two have been around for quite a while. I'll let them stay around sometimes,
Yeah.
the other two. But Tabitha, Denise, and Ashley are all good gals, and they're very dedicated and care about what they do and take a lot of pride in what they do. And each of us has a team of gals that work with us, plus our anesthetist, which you will meet later on the slides.
But people
So,
get familiar with these faces, correct? These are not
right.
just...
If I take care of you, then these are the people that you will deal with throughout the process, until you get handed off to Dr. Dibbs, who you'll meet a little bit later in the slideshow.
We can actually jump over to anesthesia. We've got Jack and Kim,
Right.
and these are the two...
They are a certified registered nurse anesthetist, and they
Glad you
both
said
have
that.
been doing anesthesia for a long time. And the reason that we have them is that these procedures are complicated procedures that may take 3.5 to 4 hours. And although as oral surgeons we remove teeth and do a lot of simpler, shorter procedures where we administer the anesthesia, it is not possible on these longer procedures that are more complicated for us to do the procedure and administer the anesthesia. It's just not possible. And so the anesthetists sort of take the pressure off in that regard, and also enables us to put our patients under general anesthesia rather than IV sedation.
What's the difference between IV sedation and general anesthesia, and why would general anesthesia be better?
Well, if with IV sedation, even those of you out there who are of the age that you may have had an endoscopy where they look down from the top, or a colonoscopy where they're looking up from the bottom, you typically are given some Diprivan or propofol, but typically a breathing tube is not inserted down into the windpipe because it's a short procedure and nobody is squirting water in your mouth. So you're heavily sedated, lightly asleep, and you don't remember anything and you think you were asleep. With these procedures that we do, we are in your mouth and we're using a lot of irrigation and squirting water in your mouth. And if a person is sedated, and everybody knows that occasionally you could swallow something down the wrong hole and you choke.
Right.
That's because the little flapper down there, that when you swallow, that little flapper called the epiglottis flips over your vocal cords so that you swallow down the swallow hole.
Yeah.
Okay. And if your reflexes are a little sluggish, and because you're sedated, and we're shooting water in your mouth, then you can gag or choke very easily. And so these longer procedures where we're using a lot of water for irrigation are not good procedures to do under IV sedation. So we do most of these under general anesthesia, where a breathing tube is inserted through the nose and down, and then that has a little balloon on the end of it that's inflated, and that protects your airway. So regardless what we're doing up in your mouth, you're totally asleep, you're not going to gag, you're not going to choke, you're out, you don't know anything about the breathing tube. And the other thing about general anesthesia is it's like the lights turned off and the lights turned back on. So you can have a 3.5 hour procedure and there's absolutely no perception of time.
That's why people wake up and they say,
anyway,
I just got put to sleep.
That's the way we do these. It allows us to move on through, use a lot of irrigation. We use a lot of irrigation, a lot of antibiotic, saline irrigation, and we can do all of that because our patients are under general anesthesia administered by an anesthetist who's highly experienced in this particular field, and it just works well. It just works.
So it's very important to have two people like Jack and Kim who've been
Right.
around for many years.
Yeah, because
you can see their experience.
not all anesthetists are adept at inserting the breathing tube through the nose and down. They all are good at putting it through the mouth and down. Because all of these people have worked in hospitals and outpatient surgery centers, and if you go to have just any old thing where they're not working in your mouth, then the breathing tube goes through your mouth and down.
Of course, because it's
So
easier.
for us, it has to go through the nose and down because we're in the mouth.
So this is our building, which designed by you and Dr. Musser,
Right?
and it houses a lot of things. So we house the anesthesia here in this building,
Right.
and also in the building, what did you guys decide to add?
Well, we added a lot of stuff.
But you added the lab, right?
Well, the main thing we initially added is that we have a generator that comes on automatically. And because we're in Florida and you get in the summer and a thunderstorm will come through. And,
Oh yeah.
you know, we can't have two people under general anesthesia and have power go out. So the main thing we did when we built our office is we built it to the specifications of an outpatient surgery center facility. And we did that by working with an organization called the Agency for Healthcare Administration. And so our building is safe. If you're here having anesthesia and a car takes out a power pole or a lightning storm takes out the power, our generator comes on automatically, just like in a hospital.
That is good to know.
Okay. So then, that was 2002. So then talking about the lab, we worked with a local outside lab until our volume increased to the point that that was not possible. So in the summer of 2014, we opened our own lab. So we do everything from a laboratory standpoint on site at this point, and have since the summer of 2013, excuse me, not 14, the summer of 2013.
So patients can customize their teeth in a timely manner because our lab is literally, well, as we're talking, above us.
Yeah, we have a team in the lab, and of course they are all highly experienced porcelain technicians and zirconia technicians, and our fellow Admir who runs the milling machines, he was the trainer for Zircon Zahn in Atlanta, and he joined us. So we've got world-renowned technicians who do the zirconia work and the porcelain work, and we're able to turn out a very nice product.
Definitely.
Yes.
Now,
And we're not
you're right.
we're not relying on an outside lab. You know, we've got the quality control and everything right here. Yeah,
in one building.
one building. Yep.
And your right-hand man in charge of...
Dr. Dibbs, yeah, he's in a unique position because there aren't many prosthodontic dentists who have their own lab right there, where actually his office is in the lab. And he is there sitting with the lab people, and he has his finger on everything that's going on. So it is almost like the dream job.
Let's go ahead and watch a short video where he talks about the lab.
Let's do that.
One of the things that really sets Florida Dental Implants apart from other offices that are doing full mouth implant reconstruction, I have my own laboratory here on site that myself and the other restorative doctors are able to use. This is invaluable. Having the ability to work so closely with my lab gives me the ability to better help my patients with the emotional side of it as well. A large number of the patients that come to us for treatment have had severe dental problems for many, many, many years, sometimes dating back to childhood. Because of the emotional concerns that they have, we really have to spend the time with the patient. That you can't rush anything. And we need to have ample opportunity to have questions asked and answered. Having my own laboratory here on site, this is invaluable. Not only in terms of having the control over the quality of the product that we're making, but the ability to, if I've got a question with the patient about, can we make this change? Is this going to be feasible? I can go across the hall, get one of my lab technicians, and all of my lab technicians have been doing this for many, many years. Bring them across the hall and they can talk to the patient themselves.
So I love that this team right here were able to change lives and be a part of that, along with you, obviously.
Well, it takes all of us.
It does.
It takes the surgeons, the lab, Dr. Dibbs, the anesthetist, the gals on each team. And so it's a culmination of putting together that business model that makes new teeth now happen. You take any link out and you can't do it.
Right. And anybody can make changes to the teeth?
Sure. The teeth that a person gets on the day of the procedure, they are what they are. They had a hand in picking those teeth in terms of the size, shape, and the color of the teeth. I'm the one primarily responsible of setting them, in their mouth, in their face, the way that I can. And then if they want to move things down or up, or move the midline around, or have larger teeth, smaller teeth, whiter teeth, less white teeth, all of those changes can come later. But yes, they can change anything they want to in terms of the teeth. And that's one reason that our New Teeth Now process does not give a person the final teeth the same day or the next day. Because there are a lot of people who wear these teeth and they go, I thought I really wanted these teeth, but I really want to change them. And so our process allows a person to change the teeth if they don't like them, It allows the tissue to swell and shrink. So then after 3 or 4 months, when we make the final zirconia teeth, the gaps that may have been created by shrinkage can be filled in. And also, we use zirconia for the final teeth rather than acrylic for the final teeth. And in the slide that Emily has up here, you'll see 2 sets of teeth. They're both upper bridges. And the top is zirconia and the bottom is acrylic. And these are about 5 years old. And you can see how the glazed porcelain staining and the zirconia has held up so much better, and the acrylic, which is more porous and more apt to absorb stains and odors and deteriorate looks. So the zirconia and the fact that we offer zirconia is a huge deal for our customers.
Now, both of these models are 5 years old, and I just want to point out that your first set of teeth will be made of acrylic, but they're only going to be in your mouth for 6 months, correct?
Correct. Yeah.
So you're not going to get as much stainage and stuff like that, but over a long period of time, of course, you're going to want to upgrade to the zirconia. And I say upgrade because a lot of places charge a fee for the zirconia.
But here, that's what the final teeth are. In other words, you wear that first set of acrylic teeth until we are happy that the shrinkage has taken place, that we're happy that the implants are all bonded well, and then we turn our people over to Dr. Dibbs to make the final teeth. And the final teeth are zirconia. So it's not an upgrade here.
Right.
It's just part of the package. Our package is you get zirconia teeth as your final teeth.
It's included because we have it on site, available,
It's made
ready
here.
at hand.
Yeah.
That's awesome.
Yep.
So how would somebody go ahead and get started with a procedure like this?
Well,
What do they need to do?
there's phone numbers everywhere. You can call in. These are 2 of our implant treatment coordinators, Shauna on the left, Debbie on the right. They have both worked for us for a long time, more than 20 years. They have both been clinical people as well as implant treatment coordinators. They know about as much as I do about the process and all the medical concerns that we may or may not have. And so if you talk to one of these people, or if you end up talking to one of our other people, you'll find they're also experienced as well. You may end up with Emily on the phone, or Grace, or Jason, and they also know everything about the process that we do. So
Definitely. All of the consultants on the phone will definitely be able to answer any questions. And if we don't know the answer, we will probably go to one of these amazing ladies, because they've got such good experience. They definitely know the answer. And if they don't know it, we'll go directly to you, the source. So your first appointment would be a CT scan, and you would want to come in. The CT scan is just $50, which I think is a great fee, because we're doing a 3D CT scan. Now, at their appointment, are you planning out their treatment when you're sitting and talking with them one-on-one?
Well, I am in my head as I'm looking at the scan. I'm sure that each of the 3 of us says something a little bit different. I haven't sat in with Dr. Musser or Dr. Kirkpatrick while they were doing a consult, but I use the CT scan as a teaching tool. I find that regular folks just like you guys can look at a CT scan with us explaining what you're looking at it, and you get it. I mean, it's easy to understand. And so I tried to use the CT scan as a tool and use that a lot in the explanation of what a person's bone looks like, because that seems to be, everyone goes, well, do I have enough bone to do this, doc? That's their question. Just tell me if I have enough bone to do this. I'm worried I don't have enough bone to do this. And so when we can pull up the CT scan and actually show them, and they can see it themselves and understand it, then I think that is a huge relief to most of these people.
Just like this one. So the lower left is a 3D imaging of a real person.
Correct.
And then what's going on up here in the
Well, with
right-hand
the
corner?
scans, this is more of a traditional kind of an X-ray. This would be like a picture of your backyard.
Mm-hmm.
And there's no depth of field there. So you can't tell how thick that jaw is down here, for instance. You can see that it looks big, but there may be undercuts and concavities, and it may be skinny. And so that's where these pictures on the bottom, these cross-sectional pictures, come in. And by moving this bar across, you can see the cross-sectional pictures across the entire jaw, whether it's the lower jaw or the upper jaw.
Mm-hmm.
And so this is just a really nice scan for us. And as I'm looking at it, I'm knowing, what I'm going to do. But I'm also explaining, and I always make sure before I leave a person that I feel like, and I can tell by the questions they're answering, but I always want to make sure that I feel like the person has got it.
Right.
Because, if a person leaves here confused about whether or not they have enough bone and whether or not we can do something for them, then I have failed in my job that day. And so we spend a lot of time educating and explaining so that the person gets it. So the scan is a huge tool in doing that.
And then I think what I want to go to next is some before and afters. 'Cause I think we can sit here and talk about it all night long, but we've never had it done.
Correct.
And it's never
Yeah.
impacted our life the way it's impacted people like Bruce.
Right.
And you know Bruce on a personal level, don't you?
I know
Now,
Bruce.
you
Right.
got-
Yeah.
got
I haven't
to
seen
know.
him in a while, but here for a maintenance checkup. But yeah, I got to know Bruce pretty well. Yeah.
And his before and after is just amazing.
And Bruce had just advanced periodontal disease, and he was fighting a losing battle, and he was losing his teeth. And he was a young guy. He was married. He just was horrified about that. And speaking of periodontal disease, most people don't understand when the teeth come out, periodontal disease stops.
Wow.
And when I tell people that, they're shocked. You mean it's cured? And periodontal disease is a disease of the attachment of the tooth to the bone. And when the teeth are removed, there is no more periodontal disease. Now, you can still have bone loss, but it's not periodontal disease. And anyway, Bruce had that, and when the teeth came out, that stopped, but he had been fighting that with specialists and all that sort of thing, and was just fighting a losing battle. So, and he had a very nice outcome. He's a nice guy, and I'm happy for him. Happy that we could help him out.
You didn't just help him out, you saved his life.
I don't know. We saved his life.
Periodontal
but,
disease
He's
can kill you.
well.
If left.
I guess in some certain circumstances it could contribute to ill health for sure. Some cardiovascular disease in certain circumstances. Yeah.
Wow. That is a great before and after. And then there's one more, Ione. She's one of my favourite people.
Yeah.
I love her. She has just got a personality that literally brightens up the room.
She
and
does.
you wouldn't know that from her before picture.
Well, it wasn't long after we did her procedure. As a matter of fact, she was still in her first teeth. And she came in for a checkup visit, and she said, I want to be on the website. I want to do a testimonial. And I think about that time Ted was walking down the hall, and I said, come here. And sure enough, she, there she is. But she lives over in the Orlando area, and I was doing a little educational seminar over there, which is where she and I got hooked up. And I would say that she is very pleased with her decision to come to New Teeth now and have this. And you can, she's got a testimonial on the website, and she's about as happy as you get. Really?
She is. She
Yeah.
brightens up the room. When we did her interviews, and you can go ahead onto our website and watch all of the testimonials. They are listed there. Ione's is there, and it's absolutely just amazing to watch. Thank you so much, Dr. Richards, for
Yep.
sitting here and explaining everything that we needed to talk about, because I wouldn't have been able to do it by myself. You know, I'm just not a good surgeon. Maybe I can learn. What do you think?
I think you're learning a lot.
Thank you.
Yeah.
Thank you. Well, thank you guys for watching, and it was a pleasure having everyone here. Hopefully, we will be speaking to you soon.
If you would like to view more informational videos on New Teeth Now, please click the subscribe button here. Thanks for watching.